Today, we are hitting 6 critical clinical pillars: the laparoscopic cholecystectomy, complications and bioleaks, gallbladder cancer and staging, biliary atresia and cysts, cholangiocarcinoma and biliary strictures, and finally, hemophilia, bilirubemia, and shunts.
To understand the pathology, we really have to establish our baseline normal first. So Section 1, the laparoscopic cholecystectomy. Picture the standard laparoscopic port placement. The surgeon typically stands on the patient's left side alongside the assistant. You've got your 10mm infraumbilical port for the camera, the epigastric port for the Maryland dissector, which is basically the surgeon's right hand, and the right hypochondrial port for the blunt grasper in the left. Sometimes a lumbar port is thrown in there for fundus retraction. And remember, the patient is placed in reverse Trendelenburg, head up, foot down, right side up. Why? Because gravity is your best friend here. It drops a bowel right out of the way perfectly to expose Calott's triangle. Now let's talk protocol, because this requires strict chronology before you even think about dissecting the gallbladder off the liverbed. First, establish pneumoperitoneum, get your positioning dialed in, and then do the absolute most important step of the whole surgery, dissecting Calott's triangle. Actually, it's not just dissecting it, you must achieve the critical view of safety. You have to see the cystic duct and the cystic artery lying completely bare. Only then do you apply clips to ligate the duct and artery separately, and then you cut. You never ever just blindly clip.
But what happens when this standard, everyday procedure goes wrong? Let's move to Section 2, complications and bioleaks. This is a fascinating contrast. Notice how the surgical approach literally dictates the anatomical risk for postoperative strictures. If you're doing a lab chole, a stricture is most likely going to pop up in the common hepatic duct. But if things get complicated and you have to convert to an open cholecystectomy, that risk profile shifts completely, and strictures most commonly occur in the common bile duct. It's a subtle shift, but it's a massive anatomical distinction you need to keep in mind. Okay, picture this. Your post-op patient develops right upper quadrant pain. They're spiking a fever and their leukocytes are climbing. You suspect a bile leak. Well, timing is absolutely everything here. If they present under 48 hours, you're good to surgically re-explore and repair. But if it's been more than 2 days, do not operate. The inflamed tissue is incredibly friable. It simply will not hold sutures. Instead, you're going to place an ultrasound-guided pigtail catheter to drain the boloma and cool off the sepsis. That buys you time to perform the absolute gold standard, an ERCP with stenting, which is both brilliantly diagnostic and therapeutic. For those exams or high-level clinical rounds, you've got to know these classifications for bile duct entries. Type A is your most common, a simple cystic duct or liver bed leak. But check out Strasbourg Type C. That one specifically targets leaks from an aberrant right hepatic duct, which is notoriously easy to mistake for a cystic duct during surgery. And as you slide down into the E classifications, which line up perfectly with the bismuth types, you're basically walking higher and higher up the biliary tree, right toward the hilum. So we just covered surgical trauma, but what if the pathology is way more insidious than a slipped clip? Let's see how this transitions into our next major category, cancer. Section 3, gallbladder cancer and staging. We're looking closely at adenocarcinomas now. And there's a pretty frightening clinical reality here. Unlike periampullary cancers where the patient turns yellow early on, in gallbladder cancer, jaundice is actually a late-stage feature. And not all gallbladder findings are created equal, right? Differentiating your polyps is absolutely vital. Cholesterol polyps, those little multiple pedunculated ones, carry zero risk of gallbladder cancer. Literally none. You leave them alone. But adenomatous polyps, those are bad news. They're often single, large, and sessile, meaning they're stuck totally flat to the wall. These carry a significantly increased cancer risk and demand a cholecystectomy. And keep in mind other major risk factors too, like gallstones, which are present in a whopping 90% of gallbladder cancer patients. If cancer is confirmed, the depth of invasion is your MVP for prognosis. This one table basically dictates your entire surgical game plan. T1A, where the tumor is just chilling above the muscle layer, simple cholecystectomy, you're done. But the second that tumor invades the muscle layer, T1B and beyond, everything changes. You have to step up to a radical cholecystectomy. That means taking the gallbladder, liver segments 4B and 5, plus clearing out the hepatoduodenal lymph nodes. And if you're dealing with T3 or T4 disease, you hit them with gemcitabine-based chemo first. Now, listen up, because this is a massive update for your clinical knowledge base. Sometimes you take out a gallbladder for what you think are just simple gallstones, and the pathologist calls you a few days later saying, hey, we found cancer. What do? Well, if it's T1A, observation only. If it's T1B, you take them right back to the OR for a radical cholecystectomy. But here's the crucial update.
Do not let old textbooks trick you into excising the laparoscopic port sites. Modern studies proved it does absolutely nothing for survival outcomes, so we definitively do not do that anymore.
Let's pivot away from oncology and look at congenital conditions. Section 4, biliary atresia and cysts.
We're looking at neonates now. Extrahepatic biliary atresia presents as progressive jaundice right at birth, caused by an inflammatory fibrosis of the biliary tree. And these specific anatomical associations listed here, absolute classic exam favorites. If you've got a newborn with progressive jaundice, pale stools, and they happen to have situs inversus, polysplenia, or an absent IVC, man, your clinical alarm bells should be ringing at full volume for biliary atresia.
The surgical management here is a literal race against the clock. For type 2 and type 3 atresia, where the hepatic ducts are caught up in it, we do a Kasai procedure, also known as a portoenterostomy. Basically, you resect the fibrotic, ruined ducts and anastomose a loop of bowel directly up to the porta hepatis. You absolutely want to get this done before the infant is 8 weeks old for the best shot at success. But here's the tragic reality of this disease. Despite a perfect Kasai procedure, progressive fibrosis still happens in about 20 to 30% of these kids, meaning this remains the #1 cause for pediatric liver transplants. Another tricky congenital anomaly is the choledochal cyst, basically a cystic dilation of the biliary tree. The Todani classification is your map here. Type 1 is your most common, a simple dilation of the common bile duct fixed up with a Roux-en-Y hepatojejunostomy. Type 3 is a choledococele down in the duodenum requiring an ERCP, but look at type 4 and type 5, which is Caroli's disease. When those intrahepatic ducts get dilated, a liver transplant suddenly becomes your main option. Why do we go to such aggressive lengths? Because these cysts carry a massive 10% risk of cholangiocarcinoma down the road. Just draining them isn't enough. You've got to get all that abnormal mucosa out of there. Speaking of which, let's roll right into section 5, cholangiocarcinoma and biliary strictures. One of the most notorious drivers for this cancer is primary sclerosing cholangitis, or PSC. It's an autoimmune inflammatory condition tied to HLA-B8 and DR3, and uniquely, it's actually more common in males. It has a super strong association with ulcerative colitis. And here is a fascinating quirk. Even if you take out the colon to cure the UC, the PSC keeps right on going. It doesn't resolve. This relentless inflammation creates a highly strictured, beaded appearance on an MRCP. If you see that beaded look, be on high alert, because it creates a toxic environment that is just ripe for multifocal tumors and cholangiocarcinoma. So if you are dealing with a cholangiocarcinoma, your management depends entirely on the location. A distal CBD tumor, you're looking at a massive Whipple's procedure. A Hiller tumor, which is famously known as a Klatskin tumor, that requires a resection right up to the porta hepatis and a portojejunostomy. However, here's the grim reality. Less than 30% of these patients present with resectable disease. For the vast majority, we have to shift gears to palliative care. We manage their severe jaundice by stenting via ERCP or doing a percutaneous transhepatic biliary drainage, usually alongside some gemcitabine chemotherapy. Okay, home stretch. Section 6, hemobilia, bilihamia, and shunts. Let's see what happens when the biliary tree violently collides with the vascular system. Have you ever heard of Quincke's triad? It's a classic. It's the defining clinical presentation of hemobilia, which is literally arterial blood pumping straight into the biliary tree. The patient is going to present with jaundice, a sudden upper GI hemorrhage, which usually shows up as melena, and intense biliary pain. It's very often iatrogenic, happening right after an ERCP or some kind of liver trauma. While it can sometimes be self-limiting, if you see this triad in a patient who is actively destabilizing, you are heading straight to interventional radiology for transarterial embolization to plug that bleed. Now, look at this stark contrast between hemobilia and bilhaemia. With hemobilia, as we just said, blood is leaking into the bile. But with bilhaemia, a fistula forms between a vein and the biliary tree, so the high-pressure bile leaks directly into the bloodstream. As you can imagine, that presents with wildly, rapidly progressive jaundice. It's like a two-way street, but both directions spell disaster. And because the mechanics are reversed, you need entirely different interventions. For bilhaemia, you can't just embolize. You have to stent the fistula via ERCP to block the bile from washing into the venous system. We'll wrap up today's explainer by looking at Abernethy malformations. These are congenital portosystemic shunts that divert blood completely away from the liver, leading straight to encephalopathy and rapid cirrhosis. For complete shunts, you can't just block them off. Without that portal flow, the liver simply fails. from biliary atresia in tiny infants to massive intrahepatic chilidocal cysts to these complete vascular shunts. It is absolutely fascinating how many roads in biliary pathology ultimately lead to a transplant. So it begs the question, is a liver transplant ultimately the only true cure for our most severe defects? It's an essential, provocative takeaway for your clinical reasoning and your board prep. Thank you so much for joining me on this rapid-fire explainer of the biliary tree. Keep reviewing these slides, keep asking the hard questions, and I'll catch you in the next one.